Thanks, Philip. Hello, I'm Thi Liu. Other differential diagnoses include neuropathic pain, headache including primary and secondary, odontogenic pain, psychiatric and mental illness. Neuropathic pain is pain that arises from abnormalities in the neural structure. It can be idiopathic or secondary to trauma or illnesses. Trigeminal neuralgia and glossopharyngeal neuralgia are the more common forms of neuropathic pain. Pain is extremely intense, episodic, and lasts for a few seconds, followed by total remission. Innocuous stimuli such as touching, brushing teeth, or wind can provoke pain. Unlike episodic neuralgias, continuous neuropathic pain often presents with burning sensation, paresthesia, dysesthesia, and allodynia. Common causes of continuous neuropathic pain include postherpetic neuralgia, trauma, burning mouth syndrome, atypical odontalgia, and atypical facial pain. Concerning this case, neuropathic pain can be excluded because the patient reports the intensity of pain around 2 to 5 out of 10, whereas neuropathic pain is highly intensive, shooting and electric shock-like pain. Patient with neuropathic pain is usually described pain as 11 out of 10. Headache. Primary headache includes migraine, cluster headache, tension-type headache, and paroxysmal hemicrania. Migraine headaches is usually unilateral, pulsatile, and accompanied by photophobia and or phonophobia. In addition, patients may present with prodromal aura. Cluster headache is located primarily in the orbital or temporal regions with accompanying lacrimation, swelling of the forehead or eyelids. Paroxysmal hemicrania presents similar to cluster headache, except that it is shorter in duration. Tension-type headaches is neurovascular in nature and more diffuse with dull aging pain and bilateral. Headache can also be secondary to any of the primary causes of orofacial pain. It is less likely that the patient has primary headache since the characteristic of presenting pain does not reflect that of primary headache. She may have secondary occipital headache as a result of TMJ and muscle problem. Odontogenic pain. Pain related to the oral cavities is probably the most common complaint. Sources of pain could arise from structures such as teeth, periodontium, or soft tissues. Pain related to a specific oral structure can be ruled out because it is often reproducible upon stimulation such as percussion, palpation, or thermal tests. Additionally, radiographic assessment is highly effective tool to confirm provisional diagnosis. In this case, the OPG reviews a number of pathologies of the teeth and the supporting tissues, such as periapical radiolucencies of previous endodontic treated teeth 2-1 and 4-5. The patient has a few large restorations and other radiolucencies suspected of dental caries, such as teeth 2-1, 3-5, and 3-1. These suspected pathologies should be thoroughly investigated in a comprehensive clinical examination and radiographic assessment to rule out pain of odontogenic in origin. Dental care should be a holistic approach. We should not treat the presenting complaint only. In fact, other oral health issues arise in the context of general health status should be addressed. Psychiatric or mental illness. A comprehensive medical history should include evaluation of the patient's psychological status. Many psychiatric or emotional conditions such as anxiety, depression, or chronic stress can exacerbate pain from sources that usually do not provoke pain in psychological stable patients. For example, bruxism. On the other hand, chronic orofacial pain could be the underlying factor of psychiatric disorders. Now I would like to pass on to Caleb to discuss about special tests.